Been a few hours, but it felt like days. Only been days, but it felt like months. Been gone for a year, only know like once.
Hello, welcome back to my channel. This is Jazz Life, and today I'm going to be giving a very overdue update on my journey in the ICU so far. So for those of you who don't know, I've been in the ICU for 8 months now. Yay! 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 And it's surprising. It's been over 8 months already. I'm in the surgical intensive care unit, and prior to me being an ICU nurse, I had so much like apprehension. I was nervous, and I really wasn't sure what to expect. So in this video, I'm just going to talk about what it's like being in the ICU and some of the preconceived notions I had coming in as a Med-Surg nurse. So prior to this ICU job, I was working float pool. I floated to different units, and I kind of just wanted to delve deeper because I felt like I wasn't really understanding like the full picture and what was going on. Having 5 to 6 patients and discharging and admitting, and it was just a lot. I assumed, that, like ICU nurses, like they're always chilling. Like there's this connotation that, ICU nurses are bougie and they are relaxed and they're super smart, and, it's not the ghetto. It's not the ghetto of Med-Surg. Like if you compare, there's different types of nursing, and, if you go outpatient, that's even much more relaxed. But coming from Med-Surg, I was like, in the ICU, you only have 1 patient or 2 patients. Like, how hard could it be? While I'm here having 6 patients, sometimes even 7, it's like you only have 1 patient for an entire 12-hour shift. That should be a breeze. Anyway, so when I first got to the ICU, one of the things that I quickly learned is that, in the ICU, we are charting every single hour. And if you are a nurse, you know that documentation is very important, but also it takes a lot of time to document. So that was one of the things that I quickly had to get used to, charting intake every single hour, output every single hour, vital signs every single hour. It was an adjustment. The other thing is that if you are a Med-Surg nurse and you step into the ICU, one of the first things that you'll notice is the pump, the Alaris pump or whatever infusion pump that your hospital uses. And then there is like tons and tons of medications on that pump. I'm talking there's like 3 different brains. There is multiple channels. Then there is a whole bunch of drips, piggyback drips, and all sorts of things. So in the surgical intensive care unit, we have mostly patients that have undergone some kind of organ transplant surgery. So on my unit, there's liver transplant, kidney transplant. We also have a lot of like GI surgeries that come in. We have an overflow of plastic surgery, so patients who have had breast cancer and undergone some sort of like double mastectomy, they may come in for implant surgery, or what we call like a deep flap surgery, which is basically they take fat from the abdomen, transfer it to the boobs, and then in the process sometimes they'll end up having like a nice tummy tuck. And the reason why these patients come to the ICU, because you may think, oh, like it's just like a boob job, like why do they need to be in the ICU? It's because these surgeries are very critical in terms of like making sure that the new tissue is getting adequate perfusion. So every hour we'd have to go in and make check for Doppler signals to make sure that, you know, the new breast tissue is not dying, it's not going to get necrotic, it's having enough blood flow to the area. And so that's why these patients are there. And I could go in about, you know, how long they stay and whatever. But the other type of plastic surgeries that we get are for a gender reconfirmation surgery. So basically, I've actually not seen male to female. It's more like female to male. So creating a penis or a phallus for the patient and making sure that, you know, again, like it's getting adequate perfusion. So I mentioned transplant surgeries, GI surgeries, plastics, and then we also have patients that are just there for hemodynamic monitoring. Maybe they had a major surgery or, you know, major event, and we want to make sure that, you know, we are monitoring their cardiac signals, I guess, and making sure that their blood pressure, you know, stays normal. So they may be on some form of vasopressors or vasoactive drips. We have patients that are basically there for some kind of sepsis, and so that is also a condition where probably, you know, they may need some help, you know, maintaining their blood pressure. And these patients that are intubated, they have to be sedated. Just imagine, like, you have a tube down your throat and you're not breathing on your own. If you were alert, the first thing you'd want to do is to just take that tube out, because I imagine it's very, very uncomfortable. And so with these patients, they are probably on some form of restraints, and then we have them on a sedative, usually propofol or some other like anti-agitation medication like Presidex, and then they will also be on some form of pain management. So like maybe they may be on a fentanyl drip just to make sure that they are comfortable. So one of the things that I had to learn very quickly is, you know, titrating drips, because you want to make sure that, especially when it comes to managing blood pressure, these patients probably have an arterial line in, which basically it monitors their blood pressure, and it's more accurate than like using a cuff pressure. Some of them are on like a continuous like steady drip. Other ones, like norepinephrine, you'd have to go in and titrate to make sure that the blood pressure is staying within a particular goal. And this is important because if your blood pressure is too low, then definitely you won't be perfusing your essential organs, which can result in the death of the tissues. And if your blood pressure is too high, then you're at an increased risk of having some form of like cardiac event. Like you could get a stroke if you have like, you know, pre-existing issues with that. Or if they've just like had like maybe a triple abdominal repair. Like you don't want your blood pressure to be too high, because then you risk kind of ruining the vasculature and maybe causing a bleed, because like again, you've had surgery, the blood is flowing through the vessel, and imagine if it's like pumping really hard, it could basically explode. I don't know if I'm explaining this correctly, but this is my understanding. And again, like I'm learning. So if you have been an ICU nurse for a long time, you can definitely like correct me in the comments and add on wherever I may have like messed up. The other thing that I really like about the ICU, I guess like when it comes to patient care, I remember, you know, being in Med-Surg and having 5 patients, and I'm thinking, okay, yes, I'm gonna give them medications, I'm gonna make sure that I'm managing their pain and their vital signs are normal. However, when it comes to even like hygiene, if you have 5 patients, how on earth are you going to make sure they all get bed baths? You know, how on earth are you going to make sure that they're all clean? And I mean, I guess that's what, you know, having a PCA or a CNA is for. But for me personally, in my practice, I feel responsible for my patients and their total well-being, not just giving them medications. So I don't just leave it up to the CNA, because sometimes it may only be like one CNA on an entire floor or two on an entire unit. And imagine if you have patients who are incontinent and, you know, they're having diarrhea or they are vomiting, and those patients need to be cleaned up. Like, how are you going to ensure that all those people are taken care of? I think that working as a nurse, you have to think a lot about teamwork and not just say, oh, like, that is not within my scope of practice, or oh, like, I'm too good to clean up somebody. Like, I definitely don't believe in that. So being an ICU nurse and having between 1 to 2 patients on my unit, you kind of circulate. So if you have 2 patients, one of them is probably a day bath, one of them is probably a night bath. I currently work night shift, so if it's a night bath, then that means that I'm responsible for that patient. But sometimes I'll just probably even do the day bath also, if I felt like, you know, that patient, you know, maybe they've had an incident that maybe something spilled on them and they need to be cleaned up or freshened up. I am definitely like in there, because I'm very passionate about making sure that my patients are clean. And to me, that's very important. As probably of great importance, just as making sure that their pain is taken care of. Hygiene is number 1. So I feel like being in the ICU compared to being on the Med-Surg unit where I have 5 patients, I'm able to manage the full care of my patient. And that includes even if like family comes in, and kind of like roping them in as to, you know, what's going on, what's the plan, what's the expectation for recovery. Obviously, I'm not going to say something that I don't know. I'm not going to be speaking on terms that I'm not sure about. But for what I know, I will definitely fill them in. Compared to if I have 5 patients, how am I going to be sitting here chit-chatting with the family and giving them, you know, that one-on-one care and attention? You cannot. Because whilst you're in there trying to help someone, guess what? Your call light is ringing. Someone needs payment. It's your job to fulfill all of that. And I just feel like being in the ICU, you know, even when I have downtime, I can go through the chart. I can look at, you know, I send the labs. So what are the results? You know, is the potassium high? Like, am I going to anticipate that we are going to be given blood because the hemoglobin is less than 7? Like, these are all things that it's like, I'm critically thinking, y'all. I'm critically thinking. And last week, or about 2 weeks ago, one of my patients was an organ donor, which I will go into that maybe in a different video. But it was the first time I've had a patient, you know, who was brain dead, that, you know, we were going to transplant his organs to, you know, multiple people. And that's a huge sacrifice, you know, for anyone who donates their organs, and for the families that are involved in that, because it could be very it's sad, you know. It's sad also, especially dependent on if it was a sudden death, you know. So like I was saying, my camera died, but it's definitely heartbreaking for families, you know, dealing with the death of a loved one and then feeling like someone is just gonna come and, you know, take their organs and kind of like inhumanely like strip them and hurt them, you know. There may be, you know, those kind of feelings associated with it. But basically, you know, I was leaving work, and as I was leaving work, there was kind of like a code scenario. There was a code scenario, and it was a patient that had undergone liver transplant. The first time it had failed, and this was the second one, and it was failing. You know, she had her abdomen open, like I mentioned about, you know, the Apthera device, and blood was just like shooting and shooting, like, you know, into the canister. It was just shooting. And we had to do, it wasn't my patient, but I stuck around because I was like, ooh, like something new, like I get to learn. And that's the thing, like I'm actually so excited to learn, and it's like, what more can I absorb, you know? So I stood there kind of like, okay, like what's going on? And then they were basically going to do a mass transfusion protocol, which is basically when they give a lot of blood in a limited amount of time, and they do that through a Bellman's machine. So this machine is like warming up the blood and just like shooting it through the patient. And with that kind of like blood transfusion, you may be going through like 30 bags of blood, like 30 bags. Just imagine, not one bag, 30. And you know, it's gonna transfuse it so quickly, like in under 5 minutes. And then boom, you have to get the next bag going. And I remember I was standing next to a nurse that is more senior than I am, and the charge nurse was like, you know, come in, help. And the nurse was like, you know, I don't know how to use the Bellman's machine, like I haven't been trained, I haven't been checked off on it. And our charge nurse was basically, well, like this is the time to learn, which I love that. I mean, obviously, like we weren't going to be in charge of like setting up this machine, because we won't be putting the patient at risk by using people that are inexperienced, you know, to set up something in a critical scenario. But you know, coming in and like being able to watch how it's done. And I had actually had a patient that had had a mass transfusion before, but it wasn't as emergent as this one. And even that, you know, I had the charge nurse and the help all nurse, which I'll go into, come in and kind of walk me through it and help me. But obviously, because I haven't been checked off on the Bellman's machine, which is a machine that is used for mass transfusion, I wasn't the one kind of, you know, hanging up the blood and all of that. I was basically checking off the blood. So in this scenario, that's what me and that other night shift nurse did. We came in, checked off the blood, made sure, you know, it was the correct blood type, correct unit number, and it was for that patient. And I remember actually one of the nurses that trained me initially, she was my preceptor. She had asked me to like come put on this central line dressing. It was an A-line dressing, but you know, the patient was bleeding all over the place, and here I was like coming in, like taking off the techoderm, like making sure I'm cleaning the place, like making sure I'm putting it on. And it was just very all hands on. And I remember even before we had gotten the coolers with the blood, I remember that, you know, the first time that I had the mass transfusion protocol, we had taken a chalk and kind of laid it on the floor. That way we track, you know, how many reds did we give, how many like red blood cells did we give, how many platelets did we give, how many cryo, you know, how many, you know, bags of stuff we are given, and kind of like laying them all on the floor and being organized. And even with the canisters for the negative pressure wound therapy thing, like making sure, you know, how much blood are we losing compared to how much blood are we given. And so I really do enjoy like the team effort of being in the ICU, and I love it, y'all. I love it. I feel like I finally found my place. And don't get me wrong, sometimes it is very intimidating when I come in and it's like, oh shoot, that is something I have never seen before, you know. And in those scenarios, there's always help available. You know, you can always ask questions. I appreciate that, especially when the patient is critically ill. They are on team 1, which means that our ICU team or our ICU doctors are the ones managing their case scenario. So say someone's blood pressure is suddenly in the 200s. Guess where I'm gonna go to? The ICU team. And guess where they are? Right down the hall. Compared to like being in Med-Surg and having to phone a number and not get a response, and you know, reach a nurse somewhere and be like, oh, like this doctor is in clinic, like what do you need, and leave a message. No, I can page the team and they're right there. And even if they are not the main team, it's people are quick to respond because it's the ICU. You know, you can get what you need when you need it, and I appreciate that. It makes my job as a nurse much easier. Let's see. The other thing that I would say is, obviously, being a nurse, you come across, I guess, like lots of sad circumstances. It could be, you know, families or accidents that are just like traumatic, you know, and emotionally being able to like deal with that. I guess like when I was in Med-Surg encountering my first patient death, you know, it was very overwhelming. And now being in the ICU where, you know, people are basically dying every day. First of all, I feel like you get to have a different lens on life. You get to have a different appreciation on life. But secondly, you realize how important it is to take care of your mental health. Because if I am not well, if I am having drama in my personal life, if I am emotionally unstable, how am I going to come in and be the refreshing energy that my patient needs, and be someone that, you know, can console my patient and their family? How am I going to be that person when I'm in shambles? You cannot, you know. And that's why it's so important as a nurse or whatever you do to make sure that you have a balance, to make sure that you are taking care of yourself, you know. And for me, one of the ways that I've been doing that is exercising, making sure that I'm eating well, making sure that, you know, I'm getting my vitamins, and making sure that I'm even staying hydrated, because you could get to work and then be walking around 6 hours later, you're like, wait, I haven't had a sip of water. And this happens. This happens not only in Med-Surg, but in the ICU. Nurses are sacrificing their well-being to take care of other people. And as much as like you could say, oh, like, yeah, like it's the nature of the job, you need to take care of you. You cannot pour out of an empty cup. How are you going to take care of other people when you are not taking care of yourself? Make it make sense, you know. And maybe this is a little harsh, but I have come to realize this like the hard way. You know, when I am caring for a patient, and because like I have my own issues going on, I need to go to the bathroom and cry. Which, like, don't get me wrong, it's natural. Like, I'm a human being. Like, I'm not a freaking robot. Like, I'm allowed to have feelings. If something sad is happening with my patient and their family, like, I can be emotional, I can cry. But I think it's very inappropriate to kind of like imagine like your patient is crying, and then next thing you know, you're crying on top of them. Like, make it make sense. So I think it's very important to like do what you have to do. If you have anxiety, find a way to manage your anxiety, be it medication, be it exercise or meditation. Find a way to manage your anxiety, because like you are in the position where you are playing such an instrumental role for a person, and it's a huge burden, it's a huge responsibility to carry. But that is what you signed up for. That is who you are. That is your profession, you know. And obviously, it's not always perfect, but you have to try. You have to try. So on my days off, you know, I'm going to the gym, taking care of myself, like going to get a pedicure, a manicure, a massage, going to a coffee shop, doing whatever brings me happiness and joy, connecting with friends and family, you know, making sure that my mental, emotional, and physical needs are met. That way, when I go to work, I'm 100% checked in. I'm advocating for my patients. You know, I'm seeing what needs to be seen. I'm seeing what may have been missed. You know, and I feel like, unfortunately, the reason why many people leave nursing, and the reason why I even at one point considered leaving the profession, is just because of how much it requires of you. You know, I've had nurses that, I think at my last job, it was a float position, and I was getting a report from a nurse, and she was literally crying. She was crying because she had had such a terrible shift. You know, the patient had yelled at her. The doctors probably called her like stupid, or, you know, because they felt like they probably are bringing their drama from outside also. And that's the thing, when you're fully aware of yourself and you're emotionally balanced, you recognize when someone is giving you attitude because they have shit going on in their life. Sorry to swear, but you realize when people are giving you attitude because they have personal things going on in their life, and they are bringing their outside drama into the workspace, and that is not acceptable. Don't get me wrong, it happens, but it is not acceptable, you know. I could talk about this on and on and on, but besides that, right now, what I need to work on is, you know, making sure continuing to learn with, you know, the pharmacology, with understanding certain disease processes and why we are doing certain things that we are doing, and not just, oh, the doctor put in an order for Solumedrol, let me go give it. No, like, I always know I'm giving this drug because of this. You know, we are doing this because of this. Because in Med-Surg, or I've seen many nurses that, you know, you just following the doctor's orders. And yeah, like, you're trusting that, you know, it makes sense. But I, for one, never want to do something that I don't understand. Because then again, like, what if that doctor made a mistake? What if pharmacy overlooked that, you know, the patient is allergic to something? You know, and speaking of, actually, I have had an experience like that. I had a patient who was allergic to morphine, and the doctor was like, yeah, go ahead and give it. And I was like, but it says in their chart that they are allergic to morphine. Why would I give that to them when they're in pain already? Oh, it's probably like a mild reaction, some itching, or maybe. I don't care if it's just itching. I am not giving something that they are allergic to. So I literally told him that, like, if you want to give that medication, you can come and give it to him yourself. But I am not going to make my patient more uncomfortable by giving them something that they're allergic to just because you think it's a mild response. Someone may do it, but I don't feel comfortable doing it, especially when we can explore other avenues. Why would I do that? Why would I make them more uncomfortable? You know, and at the end of the day, if I were to give that medication and the patient ended up having an anaphylactic reaction, guess whose fault is going to be? Not the doctor, not the pharmacist, but the nurse, because you gave it. You are the last one. Yeah. Nurse drama. The nurse drama is drama in. Anyway, my voice is a little bit. I need to drink some water. Hold on. Yeah. So, so far so good. I'm learning a lot, and I'm trying to like figure out this like whole camera situation, but once I do, best believe I will be here and I'll be chatting. All right, thank you all for watching my video. Let me know if you have any questions in the comments, any questions about what it's like in the ICU, or anything that I've said that you may have additional commentary on. But thank you. I'll see y'all. Bye.
Life move fast and you do what you want. At this time, doing what I want.